Good evening, this is Dr. Lewis Foley, one of the Exam Pro faculty. I want to welcome you to our oral board prep webinar session for Sunday, November 6, 2022. We're going to go ahead and get started. This is going to be a caseless defense type of webinar. I'm going to take you through the obligatory introduction to the software. The GoToWebinar control panel is important. This is a slightly older version of what you're looking at, but the functions are basically the same. The little orange box with a white arrow allows you to collapse or expand the control panel so you can get it out of your view during the webinar. The upper portion of the control panel is very important because it determines how you will participate from an audio standpoint. By default, the software will usually pick your computer, microphone, and speakers. However, if you're in an area with a lot of background noise or you just prefer to use a telephone, you can click the audio setup button and then use telephone. You'll be given a number to dial in, an access code, and an audio PIN number. You must enter the audio PIN number in order for me to be able to unmute you so that you can participate in the webinar. The bottom section of the control panel is something that we do not use, so please don't type any questions in here because I will not know that you did that. We do use the raise a hand feature as our method of volunteering to participate in the webinar. So if you're interested in being in the hot seat, then I will have you click the raise a hand feature so that I know that you are interested. I do want to mention that all of our webinar sessions are recorded. So if you have any need to access a recorded webinar session, contact our staff at Exam Pro and they can help you with that. And tonight is a caseless defense type of webinar. So we are going to be doing practice using your case lists. And at this point, I'm going to go ahead and let you use the raise a hand feature to volunteer. And I am going to get the case lists up so that you will be able to see them. All right, so here we have the case lists for November, just making sure I had everything correct there. Okay, at this point, I'm going to be looking for volunteers. If you click the raise a hand feature, Dr. Simisola, can I come to you first?
Yes. Hello.
Yes. Can you hear me?
Yes, I can.
Okay, let me get your case list. Do you have a preference? I'm going to just change one thing on my volume.
Either.
What's that?
No preference.
No preference. Okay, let me just. Now, is your first name?
Simisola.
Oh, Simisola. Okay, so that is my bad. Or maybe I can't tell sometimes if they enter in the names in reverse on my screen. Okay, so I can pick anyone?
Yes.
Okay, I'm going to just, to start out, we'll go to GYN if that's okay with you.
That's fine.
All right, give me just 1 second. Let's talk about case number 12.
Okay.
So was this an emergency patient or was this a scheduled procedure?
It was she came in through the ED, and then I added her on. So it wasn't emergency, like it had to happen that day. I think I was able to do it the next or 2 days later. So she was admitted.
Okay, so tell me about your initial evaluation and the options that you discussed with the patient.
Oh, okay. So the patient presented mainly with the symptomatic anemia and active bleeding, but she had been having the vaginal bleeding for some time and had been at different hospitals. When I went down to see the consult, it was clear that, you know, on pelvic exam, there was definitely a mass. It looked like a fibroid, but you could not really assess much else. We did send her for an ultrasound just to get a better evaluation, and it seemed consistent with likely a fibroid. So I counseled the patient about the fact that usually we're able to do this vaginally. However, there is a risk of needing an abdominal incision if we get in and there's bleeding, or we're not able to get to the stalk, or it's more, it's not just pedunculated as I imagined it would be. So she was definitely counseled for the risk of hysterectomy as well. The patient desired fertility. She'd had one child. It was not something she was planning for in the immediate future, but it was something that she definitely wanted the option to have. So the goal was just to manage the active bleeding currently and hopefully keep her uterus.
Could you see the pedicle or the stalk on your exam?
No, it it was pretty broad based, and I needed to be able to do an exam under anesthesia in order to actually reach the stalk and see. It was a wide stalk that I had to get in several bites.
So what was your plan as far as, or what did you do to be able to remove this vaginally?
In the OR, injected pitressin to limit the bleeding as much as we could. I did it in a sort of morcellation, so it was bit by bit, and I used cautery. And then
Okay.
when
Yeah,
I
go,
got,
were you gonna say?
sorry,
No, go ahead. I was listening.
and when I reached the level of the stalk, then it was basically a matter of just clamping and suture ligating to prevent heavy bleeding.
So did you use any technique to try, besides the injection of the vasopressin, to try and isolate the stalk prior to beginning your morcellation?
Yes, I tried to get a suture around it. There was very limited room, and it was quite wide. So it was really necessary to bivalve the fibroid first in order to have access to reach behind to get to the stalk.
And when you did that, did you get significant bleeding?
No, it
Because
was, the
you used
tissue was
cautery.
very friable. But because I did tie whatever I could, so um, the bleeding was definitely not as much as I expected it would be. It was limited.
So the blood component replacement was more a factor of the bleeding prior to going to
Prior,
the OR?
that's correct.
Okay, and what blood component replacement did she require?
She actually just received 2 units of packed red blood cells and did not require anything further.
Okay, are you familiar with any techniques that have been suggested for, besides what you've already described, for trying to remove myomectomy via the vaginal approach?
The twist method,
What do you mean when you say the twist method?
you isolate you grab the mass with maybe a tenaculum anteriorly and posteriorly, and then you just kind of twist it.
Okay, any other techniques?
Mm, Can't think of anything else besides that and what I actually did.
Okay, so the two things that I was thinking about that can sometimes be helpful in a case like this, it's always a matter of trying to isolate the stalk. And if
Yes.
you, in a lot of cases, if you aren't successful with that, you can get some bleeding as a result. One technique is to try to pass an endo loop, if you can, around the myoma and up onto the stalk. Did you try to
Okay.
do that?
No, I did not. I used an actual just loose free suture.
Okay, and usually the challenge of the free suture is you can't always see very well
Yeah,
because the myoma is in your way.
correct.
And then another thing, sometimes when even with morcellation, when you get to the pedicle, and I don't know if this was a problem in your case, the pedicle may be high enough up in the cervix or lower uterine segment that it's difficult to get exposure to be able to take it as high as possible. Did you have any trouble with that?
I had a little bit of trouble with that. I ended up getting the pedicle sort of in 2 bites. Does that make sense?
Say it one more time because my internet was breaking up. I'm sorry.
I said I had to ended up getting it in 2 bites, if that made sense, to
Yes.
reinforce the first. Yeah.
Okay. And the other thing that's been described when you have a stalk that's higher up and hard to reach is to use Durson's incisions, like you might use for the breech head of a preterm delivery, of the head of a preterm breech, where you
Yes.
actually can incise the cervix, and then that allows you to sort of flap the cervix up so that you can find the
Maybe
most
more.
proximal part of the stalk.
Okay.
Okay, anyway, I don't know that this is particularly helpful for you, but it's a very interesting case. It's a very nice case because you did it vaginally. But I think the other key point from an exam standpoint is you absolutely would have to be counseling the patient for the possibility of hysterectomy or at least a laparotomy
Yes.
because
Counsel.
yeah, and you did a great job with that. So I was very happy with that.
Thanks.
Okay, yeah, I'm gonna let you out of the hot seat. Thank you.
Thanks so much.
Yes, good job. I'm going to keep moving. We're going to get more people in the hot seat here. Dr. Now I'm not. Now I'm nervous about the names, whether they're in the right order. Dr. Falloon, are you there?
Yes, I am.
Now, is Falloon is your last name, right?
Yes, it is.
Okay, all right, good. So I'm getting this figured out. Just 1 second. Which section of your list would you like me to go to?
It doesn't matter. We can do OB or office since we just did GYN.
Sure. Yeah, absolutely. Let me just get to the list here.
I might be in October if I'm not on that list.
I think I got it right here. They just aren't in alphabetical order. Okay, I'll tell you what, we'll see what OB offers here. Quick question about case number 12.
Hmm.
What was the reason for doing the delivery in the OR?
Um, she had a category 2 tracing that was not resolved with intrauterine resuscitation and was persistent for more than an hour. So I brought her to the OR, but she was in multip and ended up progressing. I checked her when we got her on the table, and she was 9 centimeters. So
Okay,
we
and
stayed
then
in the
what
OR,
did
and she had a
it?
vaginal delivery.
Okay, perfect. Okay, I'm going to move on. Let me find a different case. Okay, let's talk about case number 15. So my first question is, why do you say forceps delivery called partner to perform?
Yeah, so this was a patient who was pushing for approaching 4 hours, and at that point, maternal effort was pretty poor. She had made descent. The fetus also had a significant amount of hair and caput, and I felt like a vacuum delivery might not be successful due to those factors and an increased number of having a lot of pop-offs. I know that in those circumstances, forceps can be more successful. I am not skilled in forceps, and I have a partner who is, and who was willing to come and evaluate, and we talked to the patient about her options. And the patient at that point, when presented with the different options, desired to try a forceps delivery.
Do you know what type of forceps your partner used?
Simpsons?
And can you tell me the 4 parts of a forcep?
The 4 parts of a forcep? I cannot. Like the instrument itself.
Yes, can you describe a forcep to me in your best effort?
Yeah, so you have the blade of a forcep that goes around the fetus's head. You have the handles. You have the part of the handles that interlace. And I'm not sure what the 4th part is.
Okay. So the forceps delivery was performed, was an episiotomy cut,
No.
but you did have a perineal laceration.
Yes.
Describe to me the perineal laceration.
It was a 3B laceration, so it went greater than 50% through the external anal sphincter, but not completely through.
How did you know that you didn't have a 4th degree?
After discovering the laceration, we performed a rectal exam with a sterile glove to make sure that the rectal mucosa was intact.
And then how did you do the repair?
So I located the external anal sphincter, as well as the fascial sheath with Alice forceps, bringing them to the midline. I did an end-to-end anastomosis with a 2-0 vicryl suturing. It interrupted posteriorly, inferiorly, anteriorly, and superiorly. Again, an end-to-end anastomosis incorporating the sheath. I then completed the 2nd degree portion of the repair.
And how did you manage the patient postpartum regarding the laceration?
Yeah, postpartum, we talked about her OASIS injury, discussing needs to keep her use of stool softeners, and discussion of pain control. We did discuss that there's an increased risk of pain, infection, and breakdown with them. We saw her back in the office at the 2-week mark to make sure that that it was recovering appropriately.
And why did you give her antibiotics?
I gave her a dose of cefotetan due to the perineal laceration.
Okay. So just kind of feedback, a very nice description of the repair. Okay, very easy to understand, easy to follow. Of course, confirming there's not a 4th degree, always the first thing you want to make sure and do, because sometimes even with only a partial sphincter laceration, you could still have a laceration underneath of the rectal mucosa. So nice description of all of that. Antibiotics, I think, is considered routine at this point for this type of injury. So I'm happy to see that. Regarding the forceps, I do think that even though you don't, it's obvious you don't do forceps delivery, I think that it's knowing a little bit about forceps is helpful. Now, you described to me the instrument pretty well, and I'll tell you the 4 parts. The blade, which, as you talked about, goes against the fetal head. The handles that the operator holds on to. The lock, which is where the forceps connect. And then the part of the forceps that connects the blade to the handles is the shank. Okay, so fairly straightforward. You did a pretty good job describing the forceps. So again, I think that's nice. I was anticipating that they probably would have a Simpson type forcep because of the G1P0 and the fact there was probably some molding of the fetal head. And if you had a multip with less molding, maybe Tucker McLean's might be a choice that would be made, because the cephalic curve of the blade is going to be more acute, not as oval. So again, a little bit of basic information about forceps can go a long way if they choose to ask you. Obviously, you've made it clear that your partner did it. I'm just thinking outside the box as to things that the examiners might do to stress you out a little bit, and they might ask you a few questions about the forceps. Okay?
Yeah.
All right, nice job.
Thanks.
Let me get the next person in the hot seat. Dr. Santos, are you there?
Yeah, I'm here.
Okay if I come to you next?
Yeah.
Which section of your list would you like me to look at?
Office would be great.
Okay, let me pull it up. Just 1 second, sorry for the delay.
You're fine.
Okay, let me ask you about case number 24.
Okay.
So this patient, did she have a pap smear with part of her new OB care, or did she have an abnormal pap smear preceding pregnancy?
No, this was a patient who had been non-compliant with her pap smears prior to pregnancy, hadn't had routine screening, and she had an HSIL HPV positive pap smear at presentation to her initial OB visit.
Okay, now, if this patient had been compliant and you were her primary GYN provider, what would you recommend to her regarding cervical cancer screening, just in general, prior to knowing about this abnormal? So assuming that she had not had any history of an abnormal, what would you recommend for cervical cancer screening?
Yeah, so at her age, at 36, I would recommend cytology with HPV co-testing every 5 years.
Okay, and when we do cytology with HPV co-testing and we get an abnormal result, like in this case, you said HSIL with HPV positive, I know that we're going to plug all this information into the ASCCP app. I assume that's what you do. Is that correct? I'm sorry, I couldn't hear you. Are you there?
Correct.
Okay, so can you tell me how the ASCCP app uses the information we put in to generate a result? What is the underlying methodology that they are using?
Yeah, so essentially they calculate a patient's risk of immediate CIN3, of having immediate CIN3, and then based off of that risk, they will either recommend expectant management with repeat pap smear at some interval versus biopsy, versus sometimes they recommend immediate excision if they're very high risk.
Okay, and do you have any idea how the risk breaks down for recommending surveillance versus colposcopy versus excision?
Yes. So I know if the risk of immediate CIN3 is above 60%, they recommend immediate excision. I believe if it's between 0 and 4%, then you can continue with surveillance, or with monitoring with pap smears. And then if it's above 4%, you move to biopsy or colposcopy.
And where does HSIL with HPV positive fall in there if you don't know any other history for the patient?
Yeah, it falls into immediate excision. It's above HSIL with HPV positive would be above 60%.
But in this case, the patient was pregnant, so there was no move for excision. Instead, the decision was for colposcopy.
Correct.
If on colposcopy you saw a lesion that was suspicious for cancer, did you biopsy, by the way, during pregnancy for this patient?
I did not biopsy her. No, one of my colleagues did.
Okay, she did have a biopsy during pregnancy.
Correct. Yeah.
And do you consider that to be appropriate, or do you think that was aggressive?
No, I think that's very appropriate.
Did they perform an ECC?
No, they did not.
And do you think an ECC is warranted?
No, because she's pregnant, we do not perform any endocervical or intrauterine procedures because of the concern that it could interrupt the pregnancy. But I think if there are any suspicious lesions on colposcopy, then yes, we would biopsy those.
Okay, and based upon the fact that her HPV testing at 6 months post-LEAP, I'm sorry, that her margins were negative, you recommended the HPV testing 6 months post-LEAP, and if that testing comes back negative, then what would you recommend?
So it is after treatment for CIN3, the recommended surveillance is cytology with co-testing 6 months, and then 1 year for 3 years. And if those are all negative, then she can resume routine screening.
And based upon this result, if the patient, based on her CIN3 history, if the patient underwent a hysterectomy, would you recommend that she continue to get cervical cancer screening post-hysterectomy?
Yes. So, and just to kind of modify what I said earlier, so she would need routine screening for 25 years. But if she had a hysterectomy for treatment, then it would be yearly surveillance for 3 years if negative, and then like routine interval for 25 years.
Okay. With the last clarification you made, explain to me what you were clarifying. I just want to make sure I was following you there.
Yeah, just before I said that after 3 years of negative testing, she would resume routine screening. I was just adding on that, and it's not exactly routine because it's 20, the 25 years of screening. So depending on her age, she wouldn't be a candidate to discontinue at 65, like a low risk.
I understood. Absolutely. Okay. So I think the reason I asked you about this case, well, first of all, looking at your list, it's obvious that your practice is OB centric, okay, which is unavoidable, okay. But the point, and I wanted to make this point for you and for everybody else listening, there's a lot of anxiety about what kind of questions are they going to ask about pap smears, cervical cancer screening, and cervical cancer screening results. And I've had many people ask me, I use the app, how am I going to explain the results of the app when I can't do the app in my head? And I think that's a legitimate concern, but I think the way that we just discussed this and the way that you gave me all of this great information is the way that people should anticipate the discussion will go. It's not necessarily what the exact result of the app would be, it's how does the app arrive at that result. And I want to just point out a couple of details. The very first thing you told me was that it looks at the immediate risk of CIN3, and that is absolutely correct. And it's going to basically put patients into 3 categories: greater than 60% or greater risk of CIN3. Those patients will end up recommended for excisional procedure without colposcopy, because the colposcopy really wouldn't change anything, even if it was negative.
Mhm.
The next group have a risk of 25% to 59%.
Oh,
And those patients, you have the choice of either colposcopy or an excision without colposcopy. Then the third group will be between 4% and up to 25%. Those patients should have a colposcopy. They would not be candidates to go directly to an excisional procedure. The colposcopy should come first. Now, that's all based on immediate risk of CIN3.
Mhm.
For patients who have a less than 4% risk of less than 4% immediate risk of CIN3, then they would go to surveillance, and that's actually based on their 5-year risk of CIN3. So they could either be surveillance in 1 year, surveillance in 3 years, or for a completely normal result, of course, surveillance in 5 years. Okay. So that surveillance recommendation, 1 year versus 3 years versus 5 years, is based on the 5-year risk of CIN3. And so just to give an example, when you have no known history, so that let's say we did not know the patient's previous pap smear screening, if a patient had HSIL high risk HPV positive without genotyping, I believe they would fall just below 60%. I think if they have genotyping for HPV 16 positive, they would be exactly 60%. Okay. And so the suggestion to go straight to an excisional procedure would be appropriate, but I believe that the HSIL general high-risk HPV positive would have an option for colposcopy. But if they had genotyping HPV 16 positive, they would definitely go straight to excisional procedure. A couple of other common results, just to kind of give you guys a reference, and I'm talking about if you have an isolated cervical cancer screening result and you don't know the patient's previous history. A common thing we'll see is ASCUS high-risk HPV positive. That would give you, do you have any idea what the immediate CIN3 risk is for ASCUS high-risk HPV positive?
I mean, I'm guessing it's gonna be, I think it's gonna be intermediate, maybe like 40% or something, but I'm not sure.
No, well, for the ASCUS, atypical squamous cells of undetermined significance with high-risk HPV positive, that actually is 4.5%. So it's just high enough to get a colposcopy, okay? If you have ASCUS HPV negative, that's actually below 4%, and that person would get surveillance. And so again, I'm not telling you guys this to have you memorize individual results. I don't think the individual results matter for the oral exam, because the examiners know that we're all using the app. What matters is understanding how the app generates the recommendations, which is all based on, again, immediate risk of CIN3 or greater. And then if it's low risk, less than 4%, it looks at the 5-year risk of CIN3 or greater to determine the frequency for the follow-up surveillance. And then when you have an excisional procedure, obviously, then the recommendations go to surveillance based upon margins positive, margins negative. And so like you were describing for this case was right on. So I think, do you have any questions for me before I let you out of the hot seat?
So that was really helpful. It's a tough topic for me.
It is. It's a tough topic, I think, for all of us, because it's a change from the old algorithms that we used to just, kind of look at the result and have a kind of a path that we could memorize. So good job. I'm going to let you out of the hot seat. We're going to keep moving. Dr. Ouyang, are you there?
Yep, I am here.
Okay, and how do you say your last name?
Ouyang.
Ouyang. Okay, good.
Yep.
Okay, if I come to you next,
Absolutely.
which
I'm
list
safe.
would you like me to look at?
Either office or GYN.
Okay, let me find it. Here we go. I'll tell you what, let's go to office again and see what we have here. Okay, let's talk for just a second about case number 17.
Mhm.
So why did you do HSV serology for this patient?
I think for her, the exam was a little bit, I want to say inconclusive or not clear. So I just wanted to make sure that I'm actually treating the right cause of her lesions.
Okay, did she have a previous history of HSV?
No, she did not.
And on examination, were there any lesions present?
There were, I'm trying to remember the exact case. If I remember the right one, they were kind of spread out throughout her vulva, around her anus, and then also up to her gluteal cleft.
Did you do any testing from the lesions?
I don't remember.
Okay, if you had a patient with lesions, would you normally test the lesions or would you normally proceed to serology?
I would normally just kind of, as studying and looking through everything, I would do the lesions. Absolutely.
Okay, in this case where she had, it sounds like her history and her exam, which were not completely convincing, you did serology, and the serology showed what? What were the exact results?
That her HSV2 IgG was elevated, and I believe from what I wrote, her HSV1 IgG would have been negative.
Okay, now is that consistent with genital herpes?
It's consistent with someone who's been exposed to genital herpes.
Okay, so what did you tell the patient? How did you counsel her once you had the results back?
I discussed that just based on her presentation and the serologies I had, the most likely diagnosis was that she was having a HSV2 outbreak. And in her case, my recommendation was to start a suppressive dose of valacyclovir, and also to make sure that she refrains from any intercourse or sexual contact, but also talking to her partner about her diagnosis so that they could be treated if needed.
Now you said a suppressive dose. Did you do episodic treatment followed by a suppressive dose, or did you just start her on suppression?
Oh, sorry, I meant episodic treatment to treat this outbreak.
Okay, and how would you do that? What dose would you give her?
1 gram twice a day for 5 days to start of the valacyclovir.
And were you assessing that this was a primary outbreak or a recurrent outbreak?
In this case, I think a primary.
Okay. What did you tell her about preventing transmission to future partners?
I told her just about basically being aware of her symptoms, and that anytime she does have an active outbreak or even symptoms, that it is possible to transmit this to partners.
So if she had a future partner who was HSV naive, then what could she do to try to maximize reducing the risk of transmission?
She could be on a suppressive dose of the valacyclovir.
Okay, anything else?
Being aware of her symptoms, making sure she doesn't have any prodromal symptoms as well, because she can transmit it at that point. Maintaining good hygiene, I guess, while she's hand hygiene, general hygiene while she is in the middle of the outbreak.
Okay, so I'm just going to go back through for a second. I'm sorry, I kind of jumped around, asked you a bunch of different questions. The reason I asked you about this case was because of the serology, okay? Because usually if I see a patient with an HSV outbreak, the usual recommendation is to do testing of the lesion rather than doing serology, okay? There was no mention on the case list about having done any testing of the lesion, so I was just wondering. Now, the second thing, you were mentioning to me that the serology came back IgG positive. Makes me wonder if this could be a recurrence, because I'd be thinking IgG positive, but HSV serology is not very reliable, and I'm trying to remember off the top of my head, but I'm thinking that IgG positive outbreak, even though the patient didn't have a known history. Okay.
Right. Yeah, that's a good point.
And then when we talk about treatment, it's important to differentiate between episodic versus suppressive, and whether we're treating a primary outbreak or a recurrent outbreak, and then which medication, in this case, valacyclovir. And that's the key thing there, is just your dosing should be consistent with which thing you think you're treating. So those are kind of the key things for the initial questions. The last thing I asked you about the patient having a discordant or known HSV naive partner. This has always been a very difficult area for counseling, because there's not a perfect way to prevent transmission. You should always mention to the patient asymptomatic viral shedding is a possibility. So even in the absence of prodrome, that could be a problem. And about the best strategy is a combination of suppressive therapy for the infected partner, barrier contraception whenever there's intimate contact, and avoidance of all sexual contact when there is a prodrome or any active outbreak with that. And I hope that is helpful. Did that help?
Yeah, that is. I was thinking, my reason, I guess, saying barrier contraception is easy. I didn't say that because I was just under the impression that because it can be so widespread, just using barrier contraception really wouldn't protect the partner, so to say.
I completely agree that barrier contraception is imperfect, but the studies that have been done on this, that was basically the approach that was utilized, a combination of barrier contraception, suppressive therapy, and avoidance of any intimate contact when there is a prodrome or outbreak. So even there was a long-term study, I think it was I want to say 10-year follow-up, that was done by Glaxo, actually the manufacturer of valacyclovir. They found that using that strategy, even when couples were compliant, only reduced the transmission by about half. So it's a challenge. I completely agree with you that barrier contraception is imperfect, but this is probably that combination is probably the best that's currently available. Okay.
Yep, definitely better than nothing. I just have one more question before, just my strategy of saying, like, obviously they'll call me out serology and not having like a culture. Is it appropriate to say, in my kind of studying and kind of getting more experience, that's what I do now?
Yeah, I think you could say that. The other possibility, and you may just want to look back at this case, is if the patient came in later on in the outbreak where the lesions were basically healed, so that there really wasn't, it was really difficult to obtain any kind of a specimen from the lesions, then the serology could potentially be helpful there, because your diagnosis, you know, the swab from the lesions is likely going to be not going to help. It's not going to result. It's always
Gotcha.
good to try from the lesion first, but you can, and this is another thing, what you're suggesting, if you actually look back and you realize, oh, I didn't do the lesion, you can definitely say in the exam, well, this is a case, if I had it today, I would do slightly differently. I would start with a test from the lesion itself rather than doing serology. That is a strategy, okay?
Okay, perfect. Thank you.
Yeah, you're welcome. I'm going to try to get one more person into the hot seat before we end for tonight. And I think we can definitely do that. Just give me 1 second. Dr. Mahoney, are you there?
Yes.
Okay, if I come to you next,
Yes.
which list do you want me to look at?
I guess we can go to GYN or OB, whichever one.
Okay.
you'd
Do you have a
like.
preference, one or the other?
I haven't done much of either, so actually I haven't done any of GYN, so I guess GYN would be fine.
Okay, perfect. Just a quick question. So what was the reason for the conversion in case number 4?
So the uterus was very bulky, and having perforated the uterus with the uterine manipulator, it was hard to gain good traction in order to complete the colpotomy. And as we were dissecting into the tissue, I could not gather whether I was in the cervix or in the vagina, and so the decision was made to open and complete the procedure.
So you were pretty far along when you got to that point.
Yes, very far along.
So that must have been a very difficult decision.
It was frustrating to have reached that point, and although I had gotten to that point, I also did not quite feel comfortable going or attempting or completing from a vaginal approach, given that I did not know where I had dissected into when I was using electrocautery at the level of the cervical tissue.
At what point during the procedure did the uterine manipulator perforate?
We had made it down to the uterine arteries, and I was already trying to attempt the colpotomy, but again, because I had already perforated, and it was hard to gain enough strength to antevert the uterus and complete or begin the colpotomy posteriorly, made the decision to proceed with opening for completion.
Okay, one last question about this case. It sounds like it was a pretty difficult case even before you made the conversion. Is that true?
Prior to perforating, it was not actually. She had never had any prior pelvic surgery. There were no intra-abdominal adhesions. The anatomy was pristine, but because of that perforation, it just proved to be a lot more top heavy, and using the uterine manipulator and trying to angulate and introvert became more difficult with having lost the strength of the uterine manipulator in its proper positioning.
Okay, and the reason I was asking that question was I noticed on some of your other cases that you've listed cystoscopy, but I don't see it listed on this case. Why not?
Cystoscopy was not performed on this case in particular, given that it is not standard practice for me, and having been able to get into the abdomen and be able to palpate everything and know that we had, or I had adequately dissected the bladder off of the specimen, I did not proceed with cystoscopy.
Tell me where you would find the ureter as it courses through the pelvis.
So the ureter, once it crosses over the bifurcation of the common iliacs, dives into the medial leaf of the broad ligament, and then courses anteromedially to the ovarian vasculature, and then proceeds posteriorly beneath the uterine artery and travels approximately 1.5 centimeters lateral to the cervix, and then inserts into the bladder at the level of the triangle.
Okay. Thanks. This is a good case for discussion. Definitely, I was listening to the course of the ureter, and I could kind of piece that together as you were going. It felt like that it wasn't quite as comfortable for you verbally as it could be. Is that true?
I have been practicing it, and yet still my brain.
I got you. I got you. It's a tough. It's because we don't think out loud, so we can visualize it in our brain, but to say it is hard. And the bottom line, I think being aware of the most common sites where it might be injured during hysterectomy is really the most important part. What are those sites where it's most commonly injured during hysterectomy?
At the vaginal apex, at the level of the cervix, at the level of the uterine artery, at the infundibulopelvic ligament.
Absolutely. And when we talk at the level of the cervix, it makes me think about the uterosacral ligament and the cardinal ligament when we're taking the ligaments. That's the area there, and then under the uterine artery. Okay. I'm going to stop there for this case for tonight. And I will tell you, I think that sometimes people ask me about converting and whether converting is a problem on the case list. And I would tell you, I don't think converting is ever a problem. If you had obviously 20 cases that were conversions, there'd be a question in the examiner's mind about your selection of the appropriate approach. But having a couple of 1 or 2 or 3 on your list is evidence that you are thinking about the safest way to complete a case. We aren't always able to complete a case the way we initially planned, and making the decision, like in this case, fairly difficult decision to convert because you were so close to being done. I think it's a sign of strength rather than weakness if you are concerned about the safety of proceeding with your previously planned approach. And I think in most cases, conversion is not a problem, but more an opportunity to discuss the different considerations that went into the decision. So I want to thank you for going through that with me. Any questions for me before I let you out of the hot seat?
The cystoscopy aspect, is that problematic that some cases end up with a cystoscopy versus others? There's different reasonings in each of these cases why cystoscopy was done versus not done.
It's not a problem. There are 2 approaches to cystoscopy: either universal cystoscopy, you do it with every hysterectomy, which is not absolutely recommended, but a lot of people do, or cystoscopy based upon perceived risk or a difficulty of the procedure. And for instance, in this case where you converted to an open approach, being open often allows you to easily trace out the course of the ureter and palpate the ureter. So for this reason, in a lot of open cases, people will choose not to do cystoscopy. I think that there's never a problem if you are doing it selectively, as long as you can describe in any given case why you decided to do it or why you didn't think you needed to do it. Okay?
Okay.
Did I answer your question?
Yeah. Thank you very
Okay.
much.
Okay, you're welcome. And let me see if we have any questions, because I think there were a couple. If you have questions, if you want to hit the question mark. Dr. Santos, did you have a question?
Sorry, I just realized I was muted the whole time.
Oh yeah, no problem.
When you say suppressive therapy for the partner for HSV, is that continuous suppression or is there a postcoital dose?
No, I don't know of a postcoital treatment for HSV. It's continuous suppression for the partner who is infected, not for the uninfected partner.
Okay. I misunderstood.
And that's okay. And the reason is that it lowers the viral load, if you will, or the release of virus. And that's why it's proposed as a method. So suppression of the infected partner.
Okay,
And it would be continuous.
great. Thank you.
All right, yeah, good question. And let me see, I think there was at least one more question. Must have answered. Okay, so that is it. I don't see any other questions for tonight. I want to thank everybody for joining us tonight. There will be another webinar tomorrow, Monday, the 7th of November, structured case webinar. So please join us tomorrow night for that, and have a great night.